Hi, everyone. It's Stephanie with the Patient Story. Really excited, have been looking forward to this conversation for today. Would love to welcome Dr. Kerry Rogers, assistant professor and leukemia specialist focusing in CLL at the James at the Ohio State University Comprehensive Cancer Center. Dr. Rogers, welcome.
Thanks. I'm really excited to be here and to talk to you today.
Yeah, and lots to talk about, lots of ground to cover. We're obviously going to focus on CLL treatments, new treatments, the excitement that's happening in the field right now. If you could give a quick sort of background of yourself, that would be great.
Sure. Well, I currently live in Columbus, Ohio, and I'm actually from the Midwest. I grew up in the Chicago area. And in terms of things I really like, I have a guinea pig and I really like guinea pigs. And I also really like college football. So, that's huge at the Ohio State University. But I also did my residency at University of Michigan. So, don't tell anyone. But I did go to Northwestern for undergrad. So that's really my football team. So that's just a little bit about me. And, I work at the James and I really enjoy taking care of people with chronic lymphocytic leukemia and hairy cell leukemia. And, my major interest academically is on improving targeted agents for the treatment of both these diseases.
That's awesome. The best part of that is I'm go Wildcats. I'm also a Northwestern
Oh,
undergrad.
great.
Woo. But it seems like you're stretched thin, three Big Ten
Yeah,
identities.
that that's why I go with Northwestern because I love Northwestern football and my parents went there and we don't win enough that anybody else cares.
That's
So
true.
so if you went there, you understand that. Yeah.
I do. I do. So we'll have to have another conversation another day about all of that. But thank you so much for introducing yourself and the guinea pig part. Part of this conversation, and I think our audience knows this, is to, humanize, because when we meet oncologists, a lot of times it's obviously a very overwhelming situation and it's a very white coat and sterile sort of feeling. And it's so nice when we can break through that because I've been talking with Dr. Rogers. It's very apparent that you care about the patient so much. And so without further ado, let's dive right into this. First, of course, just in layman's terms, what is CLL? And, sort of cover some of the basics there about who's getting diagnosed and what it means.
Yeah, so CLL is a blood cancer. It's a cancer of cells called B lymphocytes. Don't ask me why they're called B lymphocytes. And those are white blood cells or immune system cells that at some point over their lifespan have turned into cancer cells. So they can go anywhere in the body that the blood goes. So you can find them mostly in the bone marrow, in the lymph nodes, in the liver and spleen, and you can also find them in the blood because it's a leukemia. The diagnosis of CLL is made when there are a certain number of these leukemic white blood cells or CLL cells in the blood. You can actually diagnose it with a blood test. And the most common way these days people come to be diagnosed with CLL is that someone else notices that their white blood count is high and then goes through the blood test and it turns out that they have CLL. So a lot of people that are diagnosed have no symptoms whatsoever and are sometimes rather confused to be asked to go to the cancer hospital to meet with me. It's also important in thinking about CLL to realize that this is the most prevalent adult leukemia, meaning there's more adults living with CLL than any other type of leukemia. And that's because people with CLL, it's commonly diagnosed, but people with it can expect to live a very long time, including their natural lifespan in many cases. And because of that, it's really important to think about how well people are going to live with their CLL because we know that the vast majority of people are going to live a very long time with it. And not everyone actually needs treatment. You only really need treatment for it when there's something to improve from the CLL.
Perfect. Thank you so much for that. Now, if it's a way of categorizing, is it true that there are two sort of more main categories of CLL in terms of how fast the cancer is growing? And then also another question people have very often is about staging, right? And I know it's a little bit different. So if you could go through that.
Yeah, so I'll do staging first if that's okay. So, unlike solid tumors like breast cancer or lung cancer, where the staging is based on how far it's spread in the body, and if it's left the site where it developed, that means people are really in big trouble. These blood cancers are staged differently because they go everywhere the blood goes, which is everywhere. So we can't use the same kind of like, oh, it's spread and that's how we stage it. So in the United States, the most common staging for CLL is something called Rai staging. It was developed by Dr. Rai, who's a very nice man if you ever get the chance to meet him. And it's staged where there's actually 0, which is just the CLL cells in the blood. Stage 1, which is just enlarged lymphocytes or enlarged lymph nodes. Stage 2, which is an enlarged liver or spleen from CLL. And then stages 3 and 4 means that there's CLL in the bone marrow that have caused people to have a low hemoglobin or to be anemic or to have a low platelet count from the CLL. So it's actually staged simply by physical exam and looking at blood counts. And many people don't need a bone marrow biopsy for staging. Some people you do need to do it to make sure you know why people's blood counts are low, but it's not always necessary. I think the other part of that was main forms of CLL and if there's really a slow growing or a fast growing type. So everybody's a little bit different. So you'll see some people that actually were diagnosed with CLL and they've had it longer than I've been a doctor. And they're actually doing fine with it. And their white count's the same as it's been for like the last couple decades. And, that's kind of, you'll see there's people that just really their CLL isn't moving very fast at all. And then you'll see some people that were diagnosed 18 months ago and their white count's gone from 15 to 200 over that time. So really, the course of the disease can be quite different in many cases, and there's some tests we can do to help us better estimate if it's going to be a slower or a faster growing CLL. One of those tests is called IgHV mutational status or immune globulin heavy chain gene mutational status, where unmutated is usually a faster growing, higher risk CLL. And I like to think of mutated as a special low risk kind of slow growing CLL. And that's actually mutating your immune globulin heavy chain gene is a normal process in B cells. And this just says whether or not the CLL cells did that before they turned into leukemia cells. There are some other tests that can help, such as something called fish panel testing, which is just a fancy way to look at chromosomes in the CLL cells, not, like the ones you pass on to your kids. And things like deletion of the short arm of chromosome 17 or deletion 17p can also mean that we'd expect the CLL to be faster growing, and something like just deletion of with deletion 13q, which is part of the 13th chromosome, and predicts they'll be slow growing. So we can use a combination of these factors to try to guess how someone's CLL is going to do. And of course, sometimes we're surprised. Sometimes, it looks like it'll be slow growing and it's not, or people with some high risk features really have an extended course where their CLL isn't causing them any issues.
Wonderful. You mentioned a couple different terms there, and I hear that the reason why it's important, of course, is it helps to inform you, whether it's slower growing or things like that. Are there any other bits of terminology that people should be more familiar with, and what do they mean in layman's terms?
Yeah, so I think one thing that really helps a lot of people that's not necessarily fancy is just knowing how to look at your own blood counts. So people get these complete blood counts all the time, and you'll see like your white count, you'll see your hemoglobin, you'll see your platelets, which are the big ones. And then below that, you'll see what we call a differential that tells you what type of white blood cells those are. So you see the white blood cell count and then the breakdown of what types of white blood cells. And you always want to look at the lymphocyte count because the CLL cells are counted under lymphocytes. So that's kind of like an unfancy thing to look at, but that's always very important because I think it's, people with CLL get a lot of complete blood counts done, and it's important to know what they're looking for. The other testing is something that's fancy test you do just on the leukemia cells. And it's always very important to just ask if this testing is done and what the results are so that you can know more about your CLL. It not only helps you predict how much trouble you might have from the CLL in the future, like time to needing a first treatment, but also can help select a treatment that might be better, or know how many treatments you might need in your lifespan, or if at some point a clinical trial might be appropriate for you. So it's really important to know those things. So the major ones are that IgHV or immune globulin heavy chain gene mutational status, a CLL fish panel. It's spelled just like the creature, but it stands for fluorescent in situ hybridization, It's an acronym FISH. And then also just a regular karyotype, which is a chromosome analysis where they look at all the chromosomes, because people with 3 or more changes in their chromosomes actually predict a higher risk CLL and can expect to have more treatment or more difficulty with it in their lifetime. People with normal karyotype, like normal chromosomes, actually expect to have less difficulty. So those are things you really want to ask about.
Thank you for going through that. That was an important question is, what should patients and caregivers be looking at when talking to their doctors? Before we move on to the newer therapies or novel agents, I'm really excited to talk to you about historically, how have we been treating CLL, and are there still medical centers that are still implementing this sort of chemotherapy? It'd be great to talk about all of that.
Yeah, so before I launch into that, it's important to realize that kind of the median age that people are diagnosed with CLL is in the mid 60s or almost 70. And so there's a lot of older people with CLL that might have other health conditions. So it's always important to think about what other health conditions someone has when planning a treatment. So it has been a goal in the field of CLL medicine for a long time to make sure that some treatments are appropriate even for older people in their 80s or even 90s with other health conditions. But I'm going to talk about more the chemotherapy for younger fit people because I think it'll be easier to understand in that setting. So we've always had some chemotherapies that could lower the white count or improve symptoms. But the mark was really moved on how long people are living with CLL or survival by combinations of chemotherapies with an antibody medication called rituximab. And the last several decades, really before my time in working in CLL, were spent developing a regimen called FCR, which is fludarabine, cyclophosphamide, and rituximab. Rituximab is the antibody, the other two are chemotherapies. And there's a similar regimen you can use in people who might be slightly less able to tolerate chemotherapy called bendamustine and rituximab. And these are highly effective chemotherapies that could be given to most people who are reasonably healthy and can control the CLL for years. It's important to know that as a first treatment, our new targeted agents, Ibrutinib, for one, and then also it was studied with a different comparator in older patients in some cases, but Venetoclax-based treatments were compared to these chemotherapies and had a longer progression-free survival, which is a measure of how long people are alive without their leukemia returning, and found that these targeted agents were actually better than these chemotherapies, meaning people lived longer without their CLL coming back if they took the non-chemotherapy targeted agents. And also they have kind of a different group of side effects that are generally better than chemotherapy. Some people still get chemotherapy, they choose to because it's different than these targeted agents, or they might have a health condition that makes the targeted agents inappropriate. But the vast majority of CLL patients these days should be receiving treatment with a targeted agent and not with a chemotherapy. It's very uncommon that you'd have to use a chemotherapy to treat CLL. The one exception to that is young fit patients. Remember, I said IgHV mutated is a special kind of like low risk, slow growing type of CLL. So people who are IgHV mutated who don't have a high risk feature such as deletion 17p can actually have 10 years or more of being alive with no detectable leukemia after getting FCR. So there is a group of younger people who are fit for chemotherapy treatment who are mutated and don't have deletion 17p or something called a TP53 mutation who might choose to get FCR because we think it might actually be curing them. I mean, I don't know what else to call 10 years of being alive with no leukemia detectable. You know, we don't usually say CLL is curable, but this is the one case where it might be. And there's a lot of risks to doing FCR, like the risk of getting a different type of leukemia called acute myeloid leukemia is there. And that happens down the road due to bone marrow damage from FCR. But that is the one case where it could be very important to offer someone chemotherapy, especially young, healthy people that might want to do a treatment course of about 6 months and then potentially never need treatment again in their lifespan. Now, it's not a guarantee that they'll never have the leukemia come back, but that is the one case where it's important to think about it. The vast majority of other people, targeted agents are safer and more effective.
How long have the targeted, agents been in use more commonly now?
Yes, that's a really good question. The BTK inhibitors were really developed kind of in the last decade, and Venetoclax kind of shortly on the heels of that. And I really think, when things are through phase 3 studies is when they start being, prescribed more commonly. So we get to use all these drugs at academic centers. People that come see us here might benefit from taking them as a participant in a clinical trial. And I've seen a lot of people who did really well, doing a research study to get a newer drug that later became approved. But really, you see this kind of become more widely available and in use by general practice hematologists and oncologists after phase 3 studies. So it's probably been for previously treated or relapsed refractory CLL. I want to say it's been about 5 years. And then, last couple years, I think it was about gosh, with the pandemic, I seem to have lost a year thinking about my professional conferences. But I think it was about 2018 that those randomized phase 3 studies comparing Ibrutinib regimens to FCR or BR reported that Ibrutinib had a longer, what we call progression-free survival, which is again being alive without leukemia. That really put those in very widespread use. There is some resistance to it just because you have to take the pills for a long time. So you take them indefinitely until either the leukemia comes back while you're taking them, you develop a side effect and have to stop taking them, or some other health condition and have to stop. But in younger patients compared to FCR, Ibrutinib even had a survival advantage, meaning you were more likely to be alive if you took the pills instead of FCR. So most people, when you explain to them that yes, it is not the first choice necessarily to take long-term pills, decide that that's better than something that has a shorter progression-free survival or doesn't work as well. So most people are more comfortable taking pills long-term when they find out that it works better than chemotherapy.
And I know a lot of this is a matter of time and being proven that it works, and then that's more convincing for people. But now, as we segue more into what you're talking about, you talked about the indefinite pill taking, which some people might not love. But yeah, if you could describe sort of the continuous novel agent therapy versus limited, time limited.
Yeah, so in both people that have taken a treatment before or are selecting a first treatment, the major standard of care options outside of a clinical trial, which of course I think participating in a clinical trial is always something to consider if you're able to do it. I've seen a lot of people benefit from that. And no, you won't get a placebo without knowing that's an option. And we have 0 CLL trials with a placebo where I work. So the two standard options are both highly effective. And so if people haven't taken either class of drugs, they're both very good, and you can kind of pick based on preferences and side effects. There's BTK inhibitors. So those are pills that are a drug that targets a protein called BTK that binds the protein and inhibits it, and that blocks a cell signaling pathway called B cell receptor signaling. This makes the CLL cells not behave like CLL cells and die off over time. The two main drugs that are approved for CLL are the first drug that was approved, Ibrutinib, which is a once daily pill, and the second drug, which is a little more selective, so it targets fewer things than Ibrutinib does. Both mainly target BTK. That's a twice daily pill. It's called acalabrutinib. So ibrutinib and acalabrutinib are both excellent options. They're usually given by themselves, although they can be given with an antibody medication in some cases. The other option is another oral targeted agent that is Venetoclax. It inhibits a protein called BCL2, which is an anti-cell death protein. So if you block an anti-cell death protein, it's like a double negative, and it kills the CLL cells, and it kills them really fast. So that is a problem. The drug has to be started slowly so people can be monitored, because it can just work so quickly that it causes something called tumor lysis syndrome. That's usually given with and it can be given safely. It's just requires some monitoring. That's usually given with an antibody. And the thing with the Venetoclax treatments is that it's a shorter duration. So if people are taking it as a first treatment, you give it with an antibody called Obinutuzumab and take it for 1 year. If you're giving it after people have already gotten treatment, you usually give it with an antibody called Rituximab, and you take it for 2 years, and then you can stop taking it. So it's like a time limited treatment versus BTK inhibitors. You kind of take indefinitely till they stop working or you develop side effects and have to quit. Some people have very strong feelings about if they want to take something and just get it done and stop, or if they're just fine adding another pill to their pill box, and they don't want to bother with antibody infusions, just want to take some pills and go back to working or golfing or whatever it is they want to do. Both are usually tolerable for the majority of patients. The ones you take long term, obviously, for some patients have more chronic side effects because you take them for longer, and they have very different kinds of side effects for people.
Actually, that's a really important point. For so many people, the question is this balance. So whether it's I want to take a pill indefinitely, or have something that has this sort of definitive date, at least for now. Also, on top of that is the side effects question, because it's a quality of life issue, right? Um, can you talk about that in terms of, what the different side effects seem to be and how people seem to be able to manage them?
Yeah, absolutely. So the other thing that's really important is that both these treatments are so effective. If you've never taken Venetoclax or a BTK inhibitor before, you can really pick based on your preference for treatment duration, but also what side effects may or may not matter for your other health conditions. So the BTK inhibitors, the main ones that we worry about as doctors are that it can cause bleeding and bruising, including you can get severe bleeding sometimes. Mostly people just notice they're bruised out more than they were before. And it can cause cardiovascular side effects. So increases in blood pressure, an abnormal heart rhythm called atrial fibrillation, which is usually not life-threatening, but is very irritating to deal with. Um, and the high blood pressure can increase risk for things like heart attacks and strokes in the future. So just it can decrease cardiovascular health. The other things that people live with and notice are sometimes it can cause joint aches or pains. It can cause an inflammatory arthritis, cause diarrhea, and can cause heartburn. And rashes, although those usually go away or are less of a problem. Most people find the side effects from the BTK inhibitors tolerable, so they still go about their life with these things. But for someone that has atrial fibrillation that's been an issue for them or is taking several blood pressure medications already, this might not be the best idea to think about this class of drugs. People with bleeding disorders or that need warfarin anticoagulation really don't want to take this class of drugs if they have options, probably. Venetoclax, on the other hand, one of the main things that is an issue is just that to start it, you can get this tumor lysis syndrome with all the CLL cells die so quickly it releases toxins into the blood. That's treatable if you know about it, but if you don't, it can be life-threatening or fatal. So you actually have to start the dose and low and increase it slowly. So people take a low dose, and over 5 weeks, they increase the dose every week to get to the full dose of venetoclax, which is 400 milligrams. And they actually have to come for at least 2 days in a row for blood tests for monitoring for tumor lysis syndrome every time. And with this monitoring scheme, it's very safe, and people developing tumor lysis syndrome can get that treated usually with medications, and things seem to go very well for people, but it's a lot of hassle to do that. To protect people from tumor lysis syndrome, they also have to stay hydrated. So people that have heart failure take diuretics or have kidney impairment, which could make tumor lysis syndrome more likely to happen or more common, and also more dangerous, might not want to do this just because that's a greater risk to their health. Once people are at the kind of target dose or the treatment dose of venetoclax, it actually seems to have fewer chronic side effects than the BTK inhibitors. Diarrhea is one of those things. It can also lower, like your neutrophil count or some of your blood counts, as kind of both these drugs can. See that maybe a little more with the venetoclax treatments, especially because you get an antibody with it that can cause more neutropenia, which is a low neutrophil count. Neutrophils are infection fighting cells. So people can sit down and look at their health conditions, and if they have severe kidney impairment, really they probably want to take a BTK inhibitor. They have a lot of abnormal heart rhythm problems. They really want to take the venetoclax. So it's kind of a decision you make together with your treating physician. And I sometimes see patients that are considering their options for first treatment that ask me right off the bat, which one should I do? And I say, I don't know, we just met. I need to ask you some things about you. Then I can tell you what you might want. So, I think these are really important. And the discussion is very similar for people picking a treatment that have taken a treatment before, if they've never taken either of these classes of drugs before.
You're talking about relapsed refractory patients with CLL. Okay, so that was a great breakdown. And I think it's a lot, obviously, to cover. And to your point, it's about learning about the patients. And you had mentioned earlier, this is indicative of a great state of treatment options for patients who have CLL now, right? Because it's like, let's tailor it to your life, personal and professional. Any last thing you want to say about that? I do want to clarify too. I think you said this before. The venetoclax treatments, depending on the antibody drug that's going on, can be 1 or 2 years. Is that right? Or
Yes, the regimen to give it as a first treatment is 1 year. The regimen to give it as a treatment for people that have already taken a treatment or people who have relapsed, refractory, or previously treated CLL is 2 years. So it's actually whether or not they've taken a treatment before it determines whether or not it's 1 or 2 years.
Okay, perfect. Thank you for that. I know you're also really excited about the triple therapy. Is there anything else you want to talk about that? You were talking about the response
Yeah.
rates being very good, and I know time is an issue here.
Yeah, definitely. So, we always like to make treatment safer and better for our patients. And we had a study combining, and it's ongoing in follow up, but everyone in the study has completed treatment. And it's combining the BTK inhibitor Ibrutinib, Venetoclax, and an antibody Obinutuzumab as a treatment for 1 year. So there's, when you give more drugs together, you get more side effects. It's not a surprise. But the nice thing about this is it's 1 year. And now we're seeing how long people remain in remission at the end of that year of treatment. And so far, we're at about 3 years of follow up, and it looks very good. We've treated people with both relapsed refractory CLL and people taking this as a first treatment. And I'm really excited just to see how long people stay in remission after that, because that's really going to help us determine, what benefit this regimen might have compared to just taking a BTK inhibitor or taking venetoclax with an antibody. There are several other studies going on of BTK inhibitor venetoclax combinations, and I think it'll be really fun to see not only what the response rates are. We expect the response rates to be very high, because they are for both drugs individually, but also how long people remain in remission with this. And also, I was talking about that, like features of the CLL that we do those tests to try to figure out, who's going to have more or less problems. And we're always looking for things that might be better, particularly in our high risk patients. So we hope to learn with longer follow up who most might benefit from these. Like, is it people with deletion 17p? Like, is that going to be who's going to stay in remission longer than with other things? So that's exciting. And then I'm just super excited that, the way we really move the mark and get regimens into the standard of care in CLLs to do a randomized phase 3 trial. That's where you sign people to treatment A or treatment B. Again, there's no placebo. You're either getting A or B, and usually you know which one you're getting to after you're randomized. So you don't know when you sign up, but you know before you get treated. And there are 2 ongoing studies, one through the Eastern Oncology Cooperative Group, or ECOG, and one through the Alliance. Those are both US Oncology Cooperative Groups that do studies that are conducted at hundreds of sites across the US. And they are both randomizing patients to Ibrutinib and Obinutuzumab. So that's a BTK inhibitor and antibody. You take the antibody for a limited time, but the Ibrutinib indefinitely. And then that 3-drug combination, Ibrutinib, Venetoclax, and Obinutuzumab, given for a fixed duration. So you don't take it forever. And they're looking at progression-free survival, which is how long people are alive without their leukemia returning. And I'm just very excited to see how the 3-drug regimen stacks up to the others. There's 2 studies. One is for younger individuals, one's for older individuals, and they have a few small differences, but that's mainly what they're looking at. And I'm excited to see over the next several years how that turns out. And I've also treated several people in that study who are really excited to participate in it. You have to emotionally think it's okay to be randomized, but a lot of people thought it was kind of fun. They're like, oh, great, I'm going to get one of 2 great things. So, and I don't have to pick. And that's, I think those are going to be some things that are really exciting just to see how this works out over the next several years.
Wonderful. Wrapping up this part with the studies that are going on and that you're involved in as well. It sounds like, again, the caliber of the studies is high and the response has been great. So you really are, just to summarize, trying to see how you can tailor make maybe one treatment for assign one regimen for this particular group as opposed to the other, and then another metric would be the progression free survival lengths and rates. How long can they stay in remission? Is that right?
Yeah, so when you pick a new standard, usually you compare standard treatment, which in this case is Ibrutinib and Obinutuzumab, to an investigational treatment, which is that 3-drug combination. And then the main goal is to determine progression-free survival, which is how long people are alive without leukemia, if one's longer or shorter than the other. And that's a measure of how effective these things are. Some studies use overall response rate, but these drugs are so effective that doesn't really work out in CLL because pretty much everyone responds to these things, which is great, by the way. Then when we look at the patients in the study, we like to look at, okay, who had high risk features, who had low risk features. And then we see, hey, how did our high risk patients do compared to high risk patients with the other treatment? And then we sort of can, when we're meeting with an individual patient, get some information for them specifically about, with their CLL features, if we think one of those treatments might be better for them.
And you had actually mentioned, I forgot to ask you about this, that there were a couple things going on. One was the aim to reduce ibrutinib resistance.
Mhm. Oh,
Um,
yeah. So, ibrutinib, because you take it indefinitely, some people have their leukemia come back while they're still taking it. So we have some neat studies going on at our institution and at some other institutions across the country of similar things, looking at how can we identify who's developing resistance to ibrutinib before they actually get sick. So we can actually look at mutations in BTK, which is the protein that it binds at the drug binding target. And once people develop mutations in BTK in particular spots, we know that the drug will stop working. So we've offered them clinical trials to add a second drug like Venetoclax to try to reduce this resistance to see if we can keep the leukemia from relapsing, and so they can be healthy for longer and have their leukemia controlled well. We also, the CLL community, and we have studies here specifically doing this, are looking at adding a second drug to people who are on ibrutinib doing well. And remember, I said that ibrutinib and actually acalabrutinib 2, which is the other BTK inhibitor, change the way the CLL cells work and behave, but it doesn't actually kill them off. So lots of people still have CLL floating around, which is why we think they need to keep taking those drugs. So we're wondering if people who have been taking these drugs like ibrutinib and acalabrutinib for a year that are doing well can have another drug added to it to just knock out those residual leukemia cells so that they can be in a remission off treatment for some time. So that's a concept that's being studied in the CLL community, and we have a couple studies with that here too. And if you do that, then they won't be on it long enough to get resistance ideally.
Wonderful. And again, you had already made the point, no placebos at your clinical trials. Any last thing?
No.
I mean, I know it's super important for everyone, both now and in the future, to be involved, right, in clinical trials.
Definitely. So it's always good to know what your standard options are and what your clinical trial options are. For people that haven't taken BTK inhibitors or Venetoclax, those are good standard options for a lot of people. For people who are resistant to both those, usually clinical trials are your best option. And you always want to know what drug is being studied, how's the study going, who's been in it, and what your doctor expects from the study. In cancer trials, first of all, you would know there was a placebo because you have to sign a consent saying there's a placebo. And it's usually considered unethical to give people who need cancer treatment a placebo. So it will explain if it's randomized to two arms, what the treatments are that you would be getting. And actually, a lot of studies, especially ones we have that are studying very new treatments, are everybody gets the drug. Sometimes they're studying the dose of the drug. So you should know exactly what drugs you're getting. You'll never get a placebo without agreeing to be in a study with one. And I'm actually not sure there's any ongoing studies in CLL with a placebo right now. It's extremely uncommon. The main thing I want to say about clinical trials is that it can feel really weird to say, oh, should I really take something investigational? But many of these drugs are similar to drugs that are approved that might be better than those drugs in some way, or are drugs with a very new mechanism. And with the state of cancer research these days, we actually have a very good feeling that these drugs are going to help patients before we give them to patients. So many of them have been studied, obviously, in the lab using CLL cells. Cell lines have been studied in animal models of CLL. And we don't actually start trials with new drugs until we're fairly confident that it's going to help people. And I've seen a lot of people that have benefited from drugs that they wouldn't be able to get yet because they're not yet approved, and just really had a very good positive impact on their life being able to take these drugs prior to approval through participation in a clinical trial. And if anyone's considering it and unsure if they have someone they know in the CLL community or peer support for someone that's been in a clinical trial, it's always good to talk with people that have done it, just because the individual benefit to doing something like that, like being in a research study, can be very important.
Thank you for clearing that up. I know that doctors probably have to fight through a lot of misconceptions when it comes to clinical trials, the placebo thing, the guinea pig thing.
So people always tell me like, oh, I feel like I'm your guinea pig. I'm like, oh, you should be so lucky to be my guinea pig. You know what that thing's lifestyle is? He like
Yeah,
sits at
right.
home and eats lettuce, like
That's right. I
so
forgot you
my
love your.
yeah, I was like my personal guinea pig who is not not an experimental animal, is my pet, has like a super nice lifestyle. People would love to be my guinea pig. But really, people aren't guinea pigs as much as you think. And if you're considering a research study, make sure you get to ask all the questions about what the drug is and why being in the study might benefit you or others.
Right.
And your doctor should be able to answer those questions for you.
Right. And if they're not able to, maybe you can seek another opinion somewhere else about them, right? Okay, absolutely. Thank you so much, Dr. Rogers. Before we, I want to ask two more things. One, I know we talked about CAR T a little bit. What, in addition to CAR T, and you can talk about that as well, is on the horizon that excites you in terms of, areas of treatment for CLL patients?
Yeah, so CAR T is exciting. It's still investigational for CLL, but I've seen it help a subset of patients, especially those that are resistant to these drugs I've been talking about. And so it can be very powerful for select people, but it is a hassle to do and it is still investigational. So for people that have very good other treatment choices, it's usually not something we run to as a first treatment or even a second treatment. But it can be great for people that need that. The things I'm excited about are some drugs that are hopefully going to move up to benefit more patients. We're always trying to make treatment safer and more effective. And so there's reversible BTK inhibitors. So ibrutinib and acalabrutinib bind BTK at the same site and bind it irreversibly, meaning forever. Reversible BTK inhibitors bind at different sites than the two approved ones and bind and unbind BTK, which seems to limit some of the side effects. And also, for some reason, these drugs can work in people who are resistant to the BTK inhibitors, which you kind of expect because they bind it at a different site. But can work in people resistant to BTK inhibitors and Venetoclax. And they seem to be very well tolerated. The side effects look very favorable. So that's really, I think, reversible BTK inhibitors, such as a drug called LOXO-305, are now under study. And I think that's going to benefit a lot of patients. And then it's just exciting when I go to professional meetings to see what new types of drugs are being developed in CLL, or things like cyclin-dependent kinase inhibitors that are kind of coming back into play, because these drugs, either alone or in combination, are likely to benefit patients. And again, we keep moving the mark more and more towards safe, highly effective treatment, and it just keeps getting better. And new drugs with new mechanisms, drugs with the same mechanism but in a different way, these are the way we move the mark in CLL.
And really quickly, because people love to know you talked about side effects and reducing them with the reversible BTK inhibitors, what ones are we talking about?
LOXO 305 is the one that's farthest in development, and they just gave it a drug name, but I don't know how to pronounce it. There's also a drug by Arcule that has been in development that's quite good. And I'm sure there are some others that maybe aren't quite as far along. So it'll be really exciting to see how those come along and which ones end up benefiting people. Hopefully more than one.
Wonderful. And it does just help with the side effects in general, right? Just reducing.
Yeah, yes, because they're reversible, it binds and unbinds, so they seem to have less side effects, not no side effects. Anyone that tells you there's no side effects is lying. You never get anything for free, right? Or doesn't do anything, right? But that, and also because the mechanism is different than the irreversible BTK inhibitors, it can be used in resistance. So if someone takes ibrutinib until their leukemia comes back while they're taking ibrutinib, taking acalabrutinib isn't going to work because they have the same mechanism. But taking a drug with binding the same protein but with a different way of doing it can work after you're resistant. So this allows people to take, two BTK inhibitors before moving on to a drug like Venetoclax or some other treatment option. So they're just really effective, especially in people with really resistant CLL. And so it's not just that they're fewer side effects, but also they seem to work great, which is awesome.
This is all very exciting. Would be remiss to not ask about the hairy cell leukemia and the studies that you're involved in. And I know that it doesn't impact as many people, but exciting news on this front, right?
Yeah, it really is. So I love talking about hairy cell leukemia, which is another chronic B-cell leukemia. However, it has some different features than CLL, but also has a very long survival. Unlike CLL, it's very rare. So it's not very common to have people diagnosed with hairy cell leukemia. And Well, over the last couple decades, purine analog chemotherapy was developed for hairy cell, and it's actually spectacularly effective for the majority of patients and still widely used and should be. People can take a single course of purine analogs and be in remission for decades sometimes. But there's a group of hairy cell leukemia patients who don't get decades of remission from purine analogs or aren't able to take them for other reasons, such as side effects. And so the hairy cell community has been working on new drugs for this group of hairy cell leukemia patients that aren't expected to benefit from purine analogs like cladribine or pentostatin. There's a couple drugs in this area that are available. So moxetumab pasudotox, marketed as Lamoxity, is available and FDA approved for people. Also vemurafenib, which is not approved for hairy cell leukemia, but has been very well studied, can be used in people with hairy cell leukemia with a BRAF mutation, which is found in the majority of people with classic hairy cell leukemia. But there's still a need for new drugs for this group of patients. Those drugs don't kind of cover everybody, right? And we've actually conducted a phase 2 study of Ibrutinib, which is a drug I've been talking about in CLL. It's actually FDA approved for 4 different cancers. We've studied it in hairy cell leukemia in the group of patients that aren't expected to benefit from purine analogs, so people that have been previously treated, or people with something called the variant of hairy cell leukemia, and found that actually it can have a very long progression-free survival. So it was, I think, around 73% of people at 3 years were alive without their leukemia returning. And if we think about the group of people with hairy cell we enrolled in this study, that's actually spectacular for these people. And it's funny, the response rates don't look quite as high, but that's probably the response criteria we were using. You can really see how many people benefited looking at the progression-free survival. So I think it's really nice. This drug is FDA approved for other cancers, so it can be prescribed in hairy cell leukemia. And it's definitely a really important treatment option for people with this rare leukemia that aren't expected to benefit from therapies like purine analogs. So I think we published those results in a journal called Blood recently so that other doctors could find them and think about using that for their patients with hairy cell that might need something beyond purine analogs.
For this group of patients who didn't benefit from this, treatment that existed, what kind of, were they looking at in terms of prognosis? And then how has this new, with Ibrutinib, what have you found so far?
Yeah, that's an excellent question. I mean, the prognosis for hairy cell in general is quite good. So most people can expect to finish their natural lifespan. Some people die of infection, and rarely someone will die of the leukemia. That was really something that purine analogs got. Before, purine analog survival was actually expected to be a couple years and not a couple decades. When people don't benefit from purine analogs, usually they take more treatments and their lifespan can be shortened by this. It's still possible, depending on what treatments you get, to live for years. So it's not like people had a very, very short survival, but certainly not, the kind of decades you'd expect for people that really get a lot of benefit from purine analogs. These other treatments like vemurafenib is usually given for a fixed duration, and the relapse-free survival, which is the median relapse-free survival, which is roughly how long it is before the leukemia returns in the majority of patients, is less than 2 years. And so to see with this Ibrutinib study with 3 years, people are still, alive without their leukemia returning, almost 3/4 of them, is really quite good. And I look forward to seeing, the study's been open since I think 2013. So some people have been in it a really long time, and I look forward to continuing to see how it benefits those patients. Some people are obviously quite sick and had taken, 8 or 10 treatments before being in the study and probably wouldn't be doing very well if they hadn't been in a research study. And so it's also a nice example of how participating in a clinical trial can benefit people, because folks with hairy cell leukemia would not have had access to this if they didn't decide to be in a research study.
Right, when the standard treatments or the mainstream ones aren't working, I mean, clinical trials are so integral. So we will highlight this. And Dr. Rogers, thank you so much for all the time you spent. We will please keep us posted too on the excitement of all these studies that are going on at the James and with you. And so for, the future, we'd love to talk to you again. Thank you so much.
Sounds good. Thanks so much for having me.
And for everyone, of course, you can find Dr. Kerry Rogers' interview at thepatientstory.com, where we give human answers to your cancer questions.